This month's speaker, Dr. Nabarun Dasgupta, will provide evidence to show how variability in morphine milliequivalent calculations, or MMEs, create distortions and flawed conclusions in pain and opioid research, clinical care, and implications for health policies. Without further ado, Dr. Nabarun Dasgupta is a scientist at the Opioid Data Lab at the University of North Carolina with 2 decades of experience in opioid epidemiology and overdose prevention. His passion is telling true stories about health with numbers. Centered in epidemiology, his multidisciplinary approach draws on large database analytics, qualitative field studies, laboratory investigations, randomized trials, and community-based interventions. Through his work, he aims to amplify community and patient voices in public health. He works closely with patients with pain conditions. He believes they can be equal partners in scientific research. His lab at UNC tests street drugs from around the country to understand the implications of illicit drug supply, fluctuations on health. He also tracks street prices for prescription medications. He's the co-founder of Remedy Alliance for the People, a groundbreaking national naloxone bulk distribution nonprofit supplying millions of doses for the opioid reversal antidote to harm reduction programs. Without further ado, please join me in welcoming Dr. Nabarun Dasgupta.
Thank you very much, Dr. Darnell, and thank you so much for having me. I'm sorry I couldn't be there in person today, but I'm glad y'all are on the Zoom with me. So as Dr. Darnell said, I work at the Opioid Data Lab at UNC, and it's a collaboration between UNC, the University of Kentucky, and the University of Florida. And our studies are divided into 3 groups. So we have theory, practice, and lived experience. Theory studies are epi methods and biostatistic methods. Practice of medicine, pharmacy, and medical examiners. And then the lived experience ones are most fun, which involve research that is initiated by community members, whether they're pain patients or people who use drugs, as well as qualitative and other kind of field studies. So today I'm going to focus on one of our theory projects, which is looking at the definitions of MME. So what if we have been unwittingly calculating daily MME in different ways, but never realized it? And what happens if those differences are not based on conversion tables, but the way we calculate MMEs? I've been using MMEs in research for about 16 years. And during that decade and a half, I've had a really hard time convincing colleagues that subtle choices have big consequences. So we initiated this research to set things straight. Today, I'm going to show you something that once you see it, you can never unsee it. Something that will fundamentally change how you view daily MME and the 90 MME per day threshold. Funding disclosures are here. No industry funding is probably the most important thing here. And this research was funded by FDA and the Department of Justice, but the views expressed are not necessarily theirs. All the data that are being presented have been published, and so you can look up this paper. The DOI is there. We also have code, statistical code, and software code, equations, all of that to really nerd out to when you feel like it. I want to point out to begin with that we think about MME conversion tables as these pharmacological truths, but in reality, there's a lot of people who've pointed out the difficulties in understanding MME and some of the myths around them, including the late Dr. Fuden. And I think these are some of the better sources for this, so please go look them up. But the truth is that MMEs were devised decades ago out of a series of small randomized trials in a hospital setting where people were being converted from one opioid analgesic to another. They were based on the outcomes, and the conversion factors were not based on pharmacology, but they were based on analgesic effect. What has happened in the interceding few decades is that the same concept of what was causing equal analgesic effect has been adopted to also represent the toxicological phenomenon associated with larger doses of these medications. So that even though we think of them as pharmacological properties, they're not. They're based on pain And so when we use them in studies of overdose mortality and other toxicology, there's a big assumption that's being made that's not always made public. And I'm guilty of using them in those studies as well. And I will fully cop to that and show you more about that in just a moment. All right. The purpose of this presentation today is to show you something new. We reveal that there are even more fundamental and influential issue daily conversion factors. The problem is that there are actually 4 different ways to calculate MME per day, but these differences have been entirely overlooked in the scientific literature. The solution we offer is a clearer understanding of how to calculate daily MME and how to choose between the definitions. Daily MME has been enshrined into law in at least 14 states, which makes the assumption that daily MME is a standardized clinical metric. But MME is not a standardized clinical metric. None of the laws that have been published define how to calculate MME per day because they already assume that this is a clinically standardized metric, which it's not. But there is some face validity to the metric, to the conversion factors. So we did a study years ago on looking at the street prices for prescription drugs. We pulled from a bunch of different sources. I'll summarize briefly here in the first column there with the means. That's the price per milligram. So if we took those prices per milligram and standardized to morphine at 1, the predictive relative potencies based just on street price are very close to what you would get from an equianalgesic conversion table. I think we were using the VA's one in this, but the other, you can see that they're pretty similar in terms of what the street price demand for diverted opioids is. Does that mean that it has analgesic effect at these relative levels? Does it mean that there's toxicology at these relative levels? That's a different story. But the point is that one of the reasons why the concept of MMEs has endured is because there is some face validity in the clinic, on the street, and maybe in the toxicology. Okay, to start with, let's imagine that we give 4 analysts the same data set and ask them to identify which are the, quote, high-dose opioid analgesic patients. The same time period, same location, same patient, same prescription, same identical data set. We can even specify which conversion factors to use, so they're using all the same ones, and tell them to use 90 MME per day to define, quote, high dose. And we can tell them to use only the MME definitions that were vetted by and in the CDC guidelines. Sounds like a pretty boring experiment, right? Well, this is how it plays out. Each of these 4 analysts identified a different set of patients who are considered high dose. They agree at the extreme top end of the range, but in the space where most long-term patients fall, there was simply no consensus. What happened? How is there any room for variability when we're using the same conversion factors, the same data set? Something beyond pharmacology is happening here. To get to the root of the problem, let's give the same 4 analysts a simple scenario. Here's a patient with 2 prescriptions. We modified this example that appears in the CDC CME for the pain guidelines, the original ones, and we added 1 more prescription to make it more illustrative. So if you're following along at home, you may want to screen cap the side if you're used to doing MME calculations. I promise this won't be more complicated than basic arithmetic. So the first script is 30 mg of ER oxycodone twice a day for round-the-clock pain, 60 tablets for a total MME of 2,700. The second script is 5 mg oxycodone twice a day, PRN, and that's 14 tablets, and it comes to 105 milligrams of morphine equivalents. And the total MME then would be 2805. And look, there might be some nuance in how you calculate this. That's fine. For the purposes of this analysis, let's just assume that everyone is using these same numerators for the study. So 2,700 divided by 30 is 90 MME, right? So before the second script for the breakthrough pain, we're already hovering right at the 90 MME threshold. So this should be easy to identify which ones are the high, whether this is a high dose patient or not. So you may want to jot down 2805 because we'll see that number again in a moment. The 4 analysts would actually disagree on how much daily MME this single patient is getting. Their calculations will range from 31 to 105 MME per day, half of them saying that this is a high dose patient and the other half saying it's not. The same could happen across doctors within the same clinical practice or between a prescriber and an insurance company. So we've so far concentrated on the MME part of the MMe per day metric. What we haven't considered is the denominator, the word day. So to borrow a line from the musical Rent, the fundamental question is, how do we measure a day in the life of a patient? I'll spare you by not singing the song, but that's kind of the concept we're getting at. So I'll show you exactly how these four analysts arrived at these four very different MME per day calculations for the same patient two-script scenario. We took a careful look at all of the studies cited in the CDC guideline, the original guideline, to justify the 90 MME threshold. Of these, we found 18 that use daily MME. We combed over the methods and appendices and reverse engineered the underlying equations, which none of the papers explicitly included. Look, my own paper is on here, and I'm just as guilty for not including those equations, and I apologize. I've learned better after doing this project. So this is something I'm here to rectify today. In the accepted paper accompanying this presentation, we reproduced the verbatim extracts from these 18 papers, and I'll show you some of them in a moment. I know it's a little hard to believe, but the 18 studies used to establish the 90 daily MME threshold in the CDC guideline silently used four different definitions, all centered around how you interpret the word day. In some cases, the same authors use different definitions between studies without commenting on why they switched it up. So if people are using all these definitions, then it can't be that big a deal, right? To choose between these definitions? I don't know, let's find out. To atone for the lack of detail in my published studies, I worked with Alan Kinlaw at UNC to reverse engineer the equations that underlie these four definitions. At its heart, the four definitions are measuring something different. What we are building to is that 90 MME is not a standardized clinical metric. We face this challenge in other parts of medicine, like prostate-specific antigen tests and BMI, but we haven't noticed it in pain medicine in the same way. Next, I'm going to show you some equations, but if you don't speak scientific nerd like I do, just focus on the numbers. This slide is here for completeness. We've heard lots of amazing discussions in the pain medicine field about the pharmacology of opioids, but that's something that most patients and even most doctors don't feel comfortable challenging because they're kind of held up to be these fundamental molecular truths. In contrast, what I'm about to show you is nothing more than basic arithmetic. You can do this at home. Okay, so I'm going to briskly show you how the four equations apply to that two prescription scenario you saw earlier. The first definition we call total days supply. In this definition, the numerator is still 2805, the 2805 MME that you saw earlier. The denominator is 37 days, adding up the day supply for the two prescriptions, 30 days and 7 days. Dividing these numbers, we get 75.8 daily MME. This is by far the most common definition used in the literature. And this paper by von Korff is by far the most commonly cited four definitions of MME. And this is the metric that often shows up in clinical data dashboards like in PDMPs. Two things to note. First, the day supply can exceed the number of calendar days. Second, this definition is perverse. By adding a second script for breakthrough, you actually get a lower daily MME. On a clinical basis, this measure does not make any sense at all. But on a population level, I see this citation and measure used all the time in the literature, in part because it's so easy to calculate at large scale. The second definition is similar, but takes into account the overlapping days. So the denominator is 30 calendar days in our two-script scenario. Dividing, we get 93.5 daily MME. So just with this subtle change in denominator, we end up on either side of the 90 MME threshold. This probably makes sense to most clinicians, but it was only used in 2 out of the 18 studies cited in the CDC guideline. This is also the method that the HHS Office of the Inspector General recommends, and they provide a handy set of tools to calculate it in SAS, R, and SQL. The third definition uses a fixed number of days for the denominator. Clinicians may be baffled, but this is actually the method used in a lot of the papers that are cited in the CDC guideline, and it is the single most cited paper on the risk of dose and overdose mortality, which is this paper by Kate Dunn and colleagues. they use this definition. So this definition has also been used in CDC published studies. So going back to 2805 for the numerator, when we put 90 days into the denominator, we get 31.2 daily MME. This method, again, gets used a lot in research because it's so easy to implement, but it's a bit unclear if those findings really have clinical relevance. In the studies cited in the guideline, 90 days was the most common denominator, but some studies also use longer times, further shrinking the daily MME measure. And inpatient Medicare studies often use 13 days because that's the reimbursement cliff. So we went with, so here in this example, we just went with 90 because it's the most common. All right, finally, the fourth definition, D4, is something we call maximum daily dose. This is the definition used in the mobile app for clinicians that accompanies the CDC guideline. They call it total daily dose, but we think maximum is a better word because when you look at the equation, you see what's actually happening here. It assumes that it's the maximum prescribed dose on any one day, ignoring any large dosing from intentional self-harm or suicide. Using this definition, 90 MME plus 15 MME gives us 105. Not surprisingly, max daily dose returns the highest measurements. This definition is actually a bit tricky to implement with staggered start and overlapping scripts, but we've shared our code to help you kind of work through those if you're interested in this particular definition. It's worth noting that this definition is different from the one suggested by the HHS, Office of the Inspector General. So we have two federal agencies telling us to calculate the same metric in different ways. Again, MME is not a standardized clinical metric. One of the analysts on our team, Yaning, works with software engineers who process PDMP data and other large databases. She's been frustrated that most software vendors won't even give you enough detail to know how the MME per day was calculated, let alone explain in terms that clinical decision makers can actually use. This is a real-world practical problem that impacts clinical decision making and clinical support tools, including in PDMPs. Okay, so we've established that there are 4 ways to calculate daily MME. But hey, this is all just academic, right? How much relevance does this have in the real world? It's a fair question, so let me show you. We did a controlled experiment. Imagine we have 2 places and we observe that one place has a higher rate of opioid prescribing than the other, 8.7 versus 7.9 per 100 adults. This is exactly the setup that's used in a lot of policy and intervention evaluation and in epidemiology. For our purposes, the cause is less important. Let's just agree that a difference exists between these 2 places and that we have a reason to measure it. Given the mild imbalance of rates on this slide, we may want to know if there is a difference in the proportion of high dose, quote unquote, patients between these 2 locations. So we did a study comparing 2 locations like we would in a policy or intervention analysis. We conceptualized this as if they were 4 different papers using the exact same data set, evaluating the same exact intervention or policy or clinical behavior. The key thing to remember here is that the only source of variation, the only source, comes from the 4 definitions, and in particular, how the denominator for daily MME is used. Here are the methods. We used outpatient dispensing data from PDMPs in California and Florida. We chose a short 3-month period to avoid secular time trends and seasonality. We defined high dose as greater than 90 MME because that's what is in the guidelines, and it's not a number that we are going to be obsessing about in our clinical practice or in our regular day-to-day science, but this is the kind of threshold that's in the literature, and we wanted to make an example out of it. So we define doses as 90, high dose, quote unquote, as 90 MME, and we looked only at the solid oral and transdermal opioids. Patches should have been mentioned on the previous slide too. And so we use the CDC conversion tables for equianalytic potency. The equations allow you to substitute other potency factors, but we held them constant here because we were focused on the denominator of the word day. For the statistical analysis, we did 3 main things. First, we compared the percent of high dose patients between Florida and California, varying only the daily MME. Second, we quantified the milligram difference in average opioid dose per day, again, varying only the daily MME. Third, we conducted a meta-analysis, seeing if 4 different studies using the same data set, the same convergence factors, would have statistically agreed with each other. This method is used a lot in observational studies and clinical trials to evaluate if a set of studies are even comparable and if they can be combined for a meta-analysis and if they're measuring the same thing. All right. So for the sample size, we have about 9.5 million prescriptions representing about 4 million patients. The numbers you saw earlier were real. Here's the 3-month dispensing rates in Florida and California for the third quarter of 2018. We chose these places because these are 2 of the 3 most populous states in the country, and I'll show you some preliminary data from Texas as well. All right, here's some results. So here are the California results first. Same data, same conversion factors, but definitions D1 and D4, which are both used in clinical practice, showed a 3-fold difference in who is perceived to be high dose. Adding in the Florida results, we see a similar story, with D4 really identifying a lot more patients as high dose than the other 3 definitions. At some point, I'm going to get tired of using the air quotes, but I hope I'm in a friendly audience that understands that I'm not saying that 90 MMe is like a high dose threshold, but just using it because that's what the standard has been in the literature. It's worth pointing out that the definitions perform differently in each state. While D3 returned the fewest high dose patients in California, it was D1 that was the lowest in Florida. We also have preliminary data from the Texas PDMP for the first quarter of 2020 at the outset of the pandemic, of the COVID pandemic. And you see a similar pattern across the 4 definitions, but the overall proportions are lower. This could be due to time trends, but also that Texas tends to prefer IR hydrocodone way more than most other states. The takeaway, across the 3 largest states in the country, the definitions disagree whether hundreds of thousands of patients should be classified as high dose or not. Taking the same data, if we were doing a policy or intervention analysis comparing the 2 places, Florida and California, 4 studies on the same data set wouldn't even come close to agreeing with each other. Was there 39% more high dose patients in Florida, or was it 84%? Those are big differences in terms of policy implementation. In fact, the heterogeneity from definition alone is so high that we wouldn't be able to combine these into a summary measure for a meta-analysis. This really calls into question a lot of how MME is used in the scientific literature. So instead of percents, we may want to know how much higher doses were how much higher doses were in one place versus the other. The 4 definitions don't even agree if the average ER-only pain patient is getting a high dose. So you can see that based on just the definition, the average dose will bounce higher and lower than this artificial 90 MMe per day threshold. So let's look at this a little bit more closely on a technical level. We're still comparing milligram difference between Florida and California. The vertical axis is average MMe per day. Each blue bar is a different definition. The way to read this chart is that the bottom of the bar is California and the top of the bar is Florida. Florida is always higher. The height of the bar is how different the states are in terms of the milligrams of morphine equivalents. Using maximum daily dose D4, you get a really big difference, but these numbers are all over the place. Ready? It gets worse. The means were highly right skewed, meaning ultra high dose outliers were driving the averages to be unnaturally high. In these situations, we turn to the medians in orange to do studies more accurately. Here's where things get even more interesting. D4, which exaggerated the differences between states using the arithmetic average, returns much less variation between states with the median. D3 median shows the least difference at 0.9 milligrams. The message here is that subtle choices have major consequences for policy and intervention interpretation. Which one of these is correct? I honestly don't know. It depends on the research question, I guess. It's not as simple as choosing something in the middle, though that's our natural cognitive tendency. Each bar on this plot could legitimately have been justified in an observational study and glossed over in the methods section. It's a mess. While they all point to doses being higher in Florida, they really call into question what is being measured. In policy and intervention studies, even small effects with large data sets can carry a lot of inferential validity because of p-values. My recommendation is to let go of the 90 MMe threshold and odds ratio in these types of studies and instead treat MMe as continuous and use multiple metrics, median and mean. At the very least, please, please, please state the equation or definition you're using, because otherwise I can't interpret any of the papers that fail to put those in. And if you look at all the dozens of papers that are published every week using MMe per day as a metric, you'll find nearly none of them reference with adequate detail which of the definitions were used and which equations would be relevant. So how do these definitions impact our interpretation? While using D3 and medians, you could conclude that there are a lot more high dose patients in Florida, but they're only getting a milligram more. Or you could conclude that there are definitely more high dose patients in Florida, but on average, they're getting a lot more, 13 milligrams per person. So if you're evaluating an intervention or policy, these subtle choices have huge consequences. Again, which of these is correct is not clear, but we do know that what I will kind of describe which one of these definitions I think is better for the research setting at least. When you break this analysis out by IR and ER opioids, you see a lot of heterogeneity. So much so that a meta-analysis would conclude that these studies were so heterogeneous that you couldn't combine them to summarize in a meta-analysis summary statistic. The other incredible thing is patient selection. In pharma-sponsored observational studies, you sometimes look at people who are only getting ER opioids to make the cleanest possible comparisons without confounding from additional IR opioids. If we did the study on ER-only patients, we would actually conclude that California had higher opioid doses. Again, subtle choices, major consequences. And this is why I love epidemiology, because the devil is really in all these details. So despite variation in the underlying definition, the studies cited in the CDC guideline consistently found an increased risk of fatal overdose above 90 MMe per day. The simplest explanation is that this observation is the artifact of turning a continuous metric into one that is categorical. All except for 2 of the studies categorized MMe using 90 to 120 milligrams as the lower bound for the highest stratum. And I'll show you this visually in just a few minutes. Our study supports FDA's contention that overdose risk with opioid analgesics is a continuous function and rare. A big part of the issue is overlapping scripts. These really impact how the definitions perform. So how common are overlapping day supply? 42% of prescriptions overlapped with another script in our sample. It affected 1 out of every 4 patients, including most long-term opioid patients. Let me address the epidemiologists and methods folks in the audience for a second here on this technical level. It may seem that choosing one definition and applying it over time would be less worrisome, right? In most other countries, this is true. However, when you look at the equations carefully, 2 specific time trend scenarios emerge as problematic in the United States. First, if overlapping scripts decrease over time, choosing definition 1, total day supply, will attenuate the intervention effects compared to definition 2, which is on therapy days. So they will attenuate the effects differentially at earlier time points. Second, if IR and ER opioid dispensing don't both decline at the same rate over time, so it's the assumption of non-parallel linearity, the same thing will happen. Both of these prescribing trends happened in the US over the last decade, seeing faster declines in ER versus IR opioids. So we're doing simulation studies to quantify this, but in preliminary work, the amount of discrepancy that you would get by using the same, by saying like, okay, I'm just going to use one definition over time in the United States over the last 10, 15 years would lead to an artificial 33% discrepancy. I'm happy to go into more details about the longitudinal aspect of this, but those are some of the kind of broad points for epidemiologists trying to operationalize these definitions. We also explored what happens at the threshold boundary, comparing 90.0 versus 90.9. So like, where precisely do you draw the line for a high dose? Published studies often don't make clear whether their 90 MMe threshold is 90.0 or 90.9. These are like small methods details that like get left out of papers, but we really should be paying attention to them. If you shift the high dose threshold from 90.9 down to 90.0, you increase the number of high dose patients by 15%. That means there are a lot of patients who are being held at this artificial threshold despite the definitions not being clinically standardized. I found that to be astounding that this is happening right at that threshold, and even a small difference in where you round and how you round can have a 15% difference on whether you consider a patient to be high dose or not. June, an analyst on our team, thought this was unexpectedly huge too, and I agree. He points out that these little changes in studies can lead to a lot of misclassification. So we quantified the extent of that misclassification. Think of this like a doctor and an insurance company setting the threshold on either side of the boundary, either 90.0 or 90.9, so within rounding error, right? Using definition 1, the insurance company and the physician would disagree for 1 out of 56 patients whether the beneficiary was a high dose patient or not. With definition 4, it'd be 1 out of 30. It's worth noting that definition 3 is the most robust to this kind of discrepancy. In Florida, using definition 1, 18 out of every 1,000 opioid patients are getting exactly 90 MMe per day. And using definition 4, 34 out of every 1,000 opioid patients are getting exactly 90 MMe per day. So which okay. So here are some all medications as prescribed, not as described, and we did not consider other sources, whether pharmaceutical or unregulated opioids. We did not try to differentiate cancer from non-cancer pain, and we did not consider atypical mu-opioid receptor agonism for respiratory depression, such as tapentadol or buprenorphine, and we did not consider pharmacist-based variations in day supply calculations, which is part of some other research studies we're doing. And finally, we did not consider any social and structural determinants that would change the MME calculations. But at the end of the day, what we're really trying to do is figure out what the definitional aspect and how the word day is operationalized in MME per day. So which definition should we use? So this is Tosca from our team, and she has a succinct reply to that. There's no one size fits approach, but at least we need to be showing our work. And I think that's really an important part of what we're doing here. We've heard lots of reasons for clinical caution for using MMEs. So in terms of research studies and policy and evaluation intervention, here's kind of the where the rubber meets the road. I don't think D1 should be used, period. It's not a real representation of calendar time. D2 is the version that I use. D3 is the most robust to misclassification. So if you have messy data, this one might be attractive. D4 could be useful maybe in short-term toxicity studies in opioid-naive patients without risk of suicide, but definitely should not be used for long-term situations. The inaccuracy inherent in that definition grows with time, and as you can intuit from staring at these equations long enough. But candidly, if a paper doesn't sufficiently define how they calculated daily MME, I just don't read it anymore. I just can't make sense of it after having seen how much variation comes just from the definitions. So here's another fundamental question, right? Why do the studies that have been published consistently show increased risk at higher than 90 MME per day? I think we can take a lesson here from BMI, body mass index, which I assume everyone's familiar with, where there is, it used to be there were kind of 4 classes, underweight, normal, overweight, and obese. And as the population has grown older and larger, now we have all these other obese categories. So this is kind of a distribution. I think these data are actually from Australia, but the distribution looks similar. I like the pretty colors in this, so I chose this one. This is from a study that we did in North Carolina about a decade ago, where we were looking at the 1-year risk of overdose death among patients prescribed opioid analgesic. The top graph is the absolute risk, so incidence rate per 10,000 person years, and the bottom is the incident rate ratio, pinning it at the lowest band of opioid prescribing. So I hope you guys have seen that paper before, but the concept here is what that I'm trying to get at is if we did the same thing for BMI, we would treat this risk scale, right? The dose dependent overdose risk as a continuous function. We could theoretically categorize it at different cut points, but we would definitely not be treating everybody as underweight or not underweight. That's kind of nonsensical when you look at continuous data. So this is the same graph kind of with those color bands. And what most of the studies that have been published to date showing a 90 MMe inflection point for overdose risk with prescription by prescription opioid dose have done it the way that it looks like on the top. They've used 90 as a cut point and then put everything else above that in one bucket. But we know that there are a lot of patients who are getting doses that are above 100, and the risk is not linear. And so instead of treating this as a dichotomous high and low, or even like lower gradations below 90, I think we should be taking a much more nuanced approach and looking at risk over a spectrum of actual clinically relevant dosing. On top of that, kind of going back into the studies that have shown a relationship between opioid prescribing and overdose mortality, there's two specific assumptions that have gone silently unaddressed. And this is the subject of a new paper that we have coming out in the next couple of months. It's just about to go into review, but I wanted to flag these for folks who are doing these types of studies. So the two assumptions are that first, while drug exposure was measured with product level specificity, so you can say, oxycodone patients, hydrocodone patients, hydromorphone patients, whatever it is, the outcome for all the big studies that have been published on this association was overdose from any substance. So someone who died, who received hydromorphone, but subsequently died of a heroin overdose would be treated the same way as someone who was prescribed hydromorphone and then died of hydromorphone toxicity. And I know medical examiner data are easy to beat up on in terms of how what the causal relationship is. And we know there's a lot of variation from state to state in how accurately that's measured and how much causality is put into it. Let's just assume that we're looking at states where there is a standard protocol in the medical examiner or coroner's offices for saying it's not presence of an opioid that's detected in postmortem tox, but rather the levels were high enough and there's corroborating evidence that particular medication was involved in, or that particular substance was involved in the fatal respiratory depression. The second assumption that we don't talk about is that the time between dispensed exposure and fatal overdose are generally treated as uninformative, with the common assumption that once exposed, always exposed to the analgesic. So this is kind of taking an intention to treat approach, which we do often in safety studies. But that time period, there's a lot of other things that could be happening. Doses could be fluctuating. And people could be coming off that medication. So I think these are like two really important assumptions that a lot of the studies, almost all the studies to date have made, but we haven't made these explicitly clear. So this is where we're going. This is where we're headed with our next set of research, which I'll be able to present on very soon once that paper gets published or reviewed. The fundamental thing that you need to understand here from what I'm saying is that these two assumptions conflate distinct causal pathways that are separated in time. And by this, I'm talking about 4 possible causal pathways. And I'm generalizing here, but this is kind of where we think, the pathways we think where medical opioid exposure may subsequently be associated with overdose deaths. And this is, again, it's not a high frequency event in our studies in North Carolina. we found the 1-year risk of overdose among pain patients to be like 0.02%. So these are very rare events, but this is a important question that a lot of people are trying to study. So we're trying to make the assumptions more clear so that we can have better data. So I think there are, and feel free to disagree with this, but there are 4 general causal pathways. And the reason we break these out is because the kind of statistical methods you need and epi study designs you would use to measure each of these causal pathways is different. But this is something we don't really take in, where the published studies have really not taken into account. So there could be patient behavior taking more than prescribed, and a subset of that could be people who had a previous history of substance use disorders who are placed on opioid analgesic therapy with limited guardrails and end up having trouble with those medications. There's also prescriber behavior, medication errors, too high starting doses for opioid naive patients, medication interactions, and those are a lot of the things that are controllable within a medical system. There's also this popular concept of iatrogenic exposure, whether this is real or not, that patients get predisposed to opioid use disorders from getting prescribed a medication and then eventually overdose either from leftover, diverted, or illicitly manufactured opioids. And then the 4th possible causal pathway is abrupt discontinuation, where patients on long-term opioid therapy have their doses abruptly reduced or terminated, resulting in either suicide because their pain is inadequately managed, or having to supplement from getting opioids on the street. So when we combine all these causal pathways and try to create like a omnibus association between prescribed dose and overdose death, we're actually having a lot of heterogeneity in what we're actually measuring and what the research question is. So again, we will come back. I will hopefully at a future seminar be able to give you the results from this, but the short of it is that these are things that we should be considering. So going back to the MME definitions, what do doctors and patients think? So first of all, so here's an example of like where policy matters when it comes to how you define MME. And so Arkansas Medicaid required beneficiaries with greater than 250 MME per day to be tapered to 90 milligrams per day during an 18-month period. But we saw how D4 is not ideal for patients already on opioid therapy. But when using the CDC mobile app, this could easily be the definition that gets applied clinically, while another prescriber may choose on therapy days because that definition too, which makes a lot more clinical sense. The bottom line here is that MME cannot be considered a hard threshold because it's not a standardized clinical metrics. And interventions like this and policy documents, clinical guidelines that don't define how MME per day, especially the word day, is handled, are inherently problematic in my mind. Dr. Chidji, who's one of the pain physicians and the head of pain medicine here at UNC, had this to say. While payers insist they're not dictating care because the patient can still pay out of pocket for the medication, for most patients, this is not financially feasible. So the way that MME is calculated and MME restrictions that are put on patients by insurance companies have a tangible effect on patient care, and the definitions the definitions we use are central to calculating those numbers. We also have a quote here from a pain patient who we work with, who's also a sociologist on our team. And she says, far too often, we are the victims of good intentions of those wanting to do something about the opioid overdose epidemic. But that something that is done oversimplifies the problem and pushes cookbook medicine upon those of us with complicated medical situations. We wait and we suffer, and we hope it will all get sorted so we can get the care that we need. And I think that's the sentiment here that we need to remember of patients being affected by these arbitrary definitions. Finally, Chris Delcher, who was part of the science, points out that this work is an example of how we can put PDMP data to work positively for patient care. And there are a lot of reasons why PDMPs are harmful to patients and kind of have forced physicians into different, box physicians into corners in terms of how they handle patients. And we heard about that during the last seminar series with Dr. Olivia. So in this particular instance, we were able to use the PDMP data for something useful, and we were able to educate the PDMP administrators on the importance of the MME calculation. So the key message here then is subtle choices have big consequences. What we've seen today and reinforced by a lot of the other presentations you've seen in this seminar series is proof that daily MME is not a standardized clinical metric. And so the question is, like, why has this not been detected sooner? Here's my take on it. The computational ease and the evocative lure of molecular fundamentals collide in an optimal level of cognitive complexity to engender MMEs with an unsubstantiated aura of immutability. They're not immutable. These are not standardized clinical definitions. Thank you.
Dr. Dasgupta, thank you for a terrific lecture. I want to invite everyone on the webinar. You can chat in your questions. So please chat those in. We want you to be part of the discussion. We have one here. Would you comment on gabapentin combination concerns regarding overdose?
Yes, so gabapentin, pregabalin have been promoted as an opioid sparing option, often given like during surgery or right before surgery, in the hope that people will need less opioid analgesics post-op. What we have found is that does not change. That does not actually change how much pain relief people get afterwards, and it's probably more of a marketing thing. In terms of overdose risk, I think it's hard to say. I don't see a lot of pharmacological mechanism that would lead to combined respiratory depression when it comes to gabapentin plus opioids, but it does show up on toxicology. I don't think it's a major driver of overdose, even though it does show up.
Terrific, thank you. I was so struck by how you were talking about how software vendors don't need to disclose how they're calculating MME. I'd just love to hear more your thoughts on that. You described a CDC mobile app. Is that true for the CDC mobile app as well?
The CDC mobile app doesn't break it out with enough detail, but we reverse engineered it. We figured it out. There's using kind of other CDC documents. But yeah, none of the clinical tools actually get down to this level. What you would think is a fundamental thing, but it's just not something that has been publicly disclosed in any of the clinical support tools that we looked at.
And I'm so surprised by that. I mean, you've spoken to the FDA, advised the FDA. This seems to fall under the purview of the FDA and devices. What are your thoughts?
Yeah, I agree. So like it's like we're often talking to CDER, right, which is the drug division, and then CDRH, which is the devices division. Yeah, I think it's time for them to get together and like really understand. I think that there's a great like regulatory framework for mobile apps.
Yes.
And I think these definition issues with MME calculators really need to be looked at with a careful lens.
Yeah, well stated. Next question, Steve Arians. This all seems to ignore the elephant in the room, pharmacogenomics DNA testing.
Sure. I think, pharmacogenomics and metabolism of opioids and of different kind of pain markers are really important for clinical decision making. And again, we weren't looking at a outcome of pain or of overdose in this study, right? We were looking specifically at the way that we measure opioid MME, daily MME, because that was our intent. So I agree that if you're looking at something more nuanced with like more hard outcomes, then pharmacogenomics would be an important part of that.
Terrific. Dr. William Rose, given that standard of care is determined by the practice of the prudent physician and that the medical board accusations against physicians are in large part based on the application of state-endorsed PDMP data, how can one defend the standard recognizing the room for these errors?
I think this is kind of like the part that I didn't say out loud, right? And I think that some of the prosecutions against physicians need to be relooked at in light of in light of these findings, right? There are legitimate reasons why you would use one definition versus another, and if if what the standard of care definition is has not been specified. I don't even know that it should be specified, but there is enough variation here that I think defendants who are physicians being brought up in front of their medical boards might want to look at some of this variation to push back against an arbitrary standard of care based on MME.
Terrific. Dr. Dasgupta, you made some really great concrete recommendations. Some of them I was live tweeting as you're speaking, but I'm curious, do you have a single publication or resource posted anywhere that would be a quick reference guide for your recommendations for how to minimize error in MME calculations?
Whew, I probably should do that, but I think for clinicians or researchers, right? Like
maybe both. I was just like, because I'm thinking, gosh, if people just want a takeaway summary, because I think from your talk, what we can appreciate is like, look, there's so much variability. How do we minimize that? And what do you recommend for clinicians? What do you recommend for researchers? But I mean, you're the guy, so I'd love to have those resources.
I would say go with definition 2. I'll make it very simple. Make it face valid, right? Like, don't make the number of days longer than the number of days in a month, and don't assume that patients are getting one script, of an IR opioid and taking them over 90 days. I think that's kind of the bottom line. There's a lot of nuance in epi studies that gets swept under the rug, and I will admit, there's a lot of epidemiologists in my profession who don't pay attention to these details either. But there are some of us who are interested in the best types of outcomes for patients, and I think these are a part of being a conscientious and thoughtful scientist.
Thank you. Roger Nags, hopefully I'm pronouncing your name right. Does the type of pain, acute versus chronic pain, make a difference?
It does. And if you look back at the meta-analysis slide, that was where we broke it out by ER and IR opioids. We were trying to get at that indirectly because we couldn't get acute versus chronic in the data sets we had. But I think the more chronic pain patients you have in your sample, especially if you're in a practice setting where people are allowed to get IR opioids for breakthrough, more there's overlapping scripts. Or if you're in a setting where you're using multimodal, different opioid molecules at the same time, anytime when you have overlapping scripts, what happens more in chronic pain than in acute pain, you will have the definition choices will get magnified. So definitely more of a concern with the chronic pain population.
Terrific, thank you. Well, we're just about at time. I want to thank you again, Dr. Nabarun Dasgupta, for a truly informative lecture, giving clinicians, researchers, policymakers a lot to think about. Thank you so much for your important work in this space.